programs developed across many domains in family service agencies and child guidance clinics, for those of you who remember what those are. And I wondered, did any of you besides me remember I'm Okay, You're Okay parenting series? A few of you are nodding, not too many, but that was the state of the art once upon a time. Thank God we moved on from there. We got lots of parenting going on in child welfare services, as we always do, and hopefully it's becoming more evidence-based, and it's embedded in place-based initiatives and family resources. And today we're going to be talking about it in terms of a public health systems and settings. A few years ago, I was privileged to be part of a National Academy of Science Institute of Medicine panel on parenting of children 0 to 8. And one of the key findings of that work was that few professional students learn to work with parents effectively and to implement evidence-based practices. When I look at social work first, and how many of you are social workers today? All right, and I should ask also, how many of you are alums of the school? Great, welcome home. What I see is that we're not doing that much either to teach parenting, and that's one of the reasons also for the PrEP initiative and today's meeting. I can tell you as a dean that if a MSW student was denied their opportunity to take a family therapy course, they would be marching on my office. They would be very upset about that. But as far as I know, I have never had anybody yet marching for parenting education for all. Many of you are involved with parenting, but it just hasn't become a force in social work education, and that's one of the things that I'm pleased to say is we have many students here today, and we have a growing participation in teaching about parenting in the School of Social Work, and I hope today's event will accelerate that further. So we have many social workers involved with parenting across the state, in Judy centers, and in many other places, as I mentioned, and you'll be hearing about some of that this afternoon, some of our local initiatives, and I am delighted to be able to catch up with some of our local scholars, not just from social work, but outside, who will be, and practitioners who will be talking about that. We decided to structure today's event in a way that promises the best possibility for advancing a more systemic approach to parenting. I'm delighted to have these great scholars with us, and I want to thank Lisa Berlin for using her lifetime network of working on parenting research and intervention for helping to bring them here today. Finally, people have asked me, where is this event headed? Where is this event going to lead? I really don't know. We hope that we'll add to our collective expertise in Baltimore and Maryland about providing effective parenting services. I'm optimistic enough to think that new collaborations and replications will arise from today and from the work that we will do ongoing. I am committed to being part of that and using funds I'm entrusted with to enhance innovation amongst those of us who are here today and others who seek our support or involvement. I'm only certain that we will need to continue to do this work because parenting is so critical, and we're really just at the beginning of understanding how to roll out effective parenting programs. So now it is my pleasure to introduce Associate Professor Lisa Berlin, who will complete today's opening remarks and moderate our morning session. Thank you so much. Lisa.
Good morning. It's a pleasure to be here and to see you all. I take this good turnout as a sign that you share my great enthusiasm for today's agenda. Of many things, I think one of the most exciting is the opportunity today to really take what we know and connect it to what we do. To take what we know about from the science of child and family development and push it. To take what we know about what's working out there for whom and push it increasingly into what we are doing in agencies, in clinics, in homes, and in broad settings. So I'm looking forward to what we're all going to learn together today. Couple housekeeping details. Let's see, if you are collecting CEUs. That can be done at the end of the day when you submit your evaluation of the day. If you are watching this event online, streaming, you won't see video content provided by speakers, just for reasons of ethics, basically. But don't be surprised if it cuts away. A few thanks. Devin Prater, Justin Hanna, our events team, put this day together so nicely. Thank you so much. Also Sarah Wise from the Dean's Office and Matt Kahn. It's been a team effort and we really appreciate it. Okay, I want to turn now to introducing our first speaker, Dr. Daniel Shaw, who is Distinguished Professor in the Department of Psychology at the University of Pittsburgh. He also holds joint appointments there in the School of Medicine and the Center for Social and Urban Research. He directs the Pitt Parents and Children Laboratory, where the focus is on the early antecedents and prevention of childhood conduct problems. From that work, Dr. Shaw and his colleagues developed an intervention that he'll be talking about today called the Family Checkup. But first, he's going to help us set the day by presenting, by talking about integrating evidence-based parenting programs into public health systems, opportunities, and challenges. So please join me in welcoming Dr. Shaw.
So Lisa got this mic to work, but I'm offering you the lavalier mic too if you want to. Your call.
Can people hear me?
Yep.
Yes, good. I might move around. If I do, I'll yell, so this is great. Thank you, Rick and Lisa, for inviting me. It's a real pleasure to be here and share some of my questions, which you'll see in a few minutes, and some of the work we've been doing the last 20 years on the family checkup, but even some basic research before that. Emphasis on what's in parentheses here, lessons learned the hard way, too. And some of this is the journey that we've been taking since about 1999, where I got more into the intervention field. I was one of these developmental psychopathology researchers before that. So my goal in this opening is to get people enthused, excited about this area, but also ask some tough questions too that we've been encountering, at least over time. So I want to start, as you do in therapy, with the resistance, right? Get it out. Why embark on this challenging task? After all, if parenting programs are so desperately needed in public health, why aren't they already located there? And I say that somewhat sarcastically, but also with the knowledge that changing anything is very hard to do. And that to think of you're going to roll in here and do something different, there's going to be some pushback. If you get there, if you build it, will they, parents and children, come is an issue too. So I've been taught this lesson the hard way, and I'll share that in a couple minutes. Just because you have these services and you know everything doesn't mean parents in the community will actually take advantage of your great knowledge base and things like that. So be prepared for that. And that has to do with engaging with families from the start rather than after the fact. And then, of course, there's this thing called funding and resources. Even if you have a good idea and a good fit, initial funding and sustainability is a challenge. So we run into this in trying to have to diagnose 2-year-olds to get reimbursed for services with young children versus using other lines in prevention. And then you're talking about getting society to commit to early childhood. You know, it's interesting. I used to be chair of my department, and one of the things I learned there is that MRI centers lose money every year, $400,000 to $500,000 at least, and sometimes $1 million. And basically, the scientists there have made the argument that this is where science is going. You're going to lose money. Do you want to do this or not? And it's interesting how we've been very shy about that in asking for the mental health and development of our children, but Yeah, it loses money, right? But look at the dividends that you might get there. So that's the negative. Well, here's the impetus why we might want to do this. There's more than some evidence suggests that interventions early in parenting during childhood or during early childhood are more effective than starting later. This is intuitively appealing. I know some colleagues, Patty Lighton and Francis Gardner, recently showed that this isn't necessarily the fact with Incredible Years, where they're showing comparable effects with earlier and later childhood. But in most cases, we've seen some evidence. It makes more sense. We know about malleability and critical periods and those kinds of things. From my own work, and this is now wearing my basic researcher hat, but in elsewhere, we know that developmental precursors of adolescent and young adult problem behaviors, such as substance use, high-risk sexual behavior, antisocial behavior, can be identified as young as 1.5 to 2 years of age. And this is on a couple of cohorts now where we get a really good sense, and this is all prospective research. This is not an 18-year-old looking back. This is following, in our case, WIC families all the way from early childhood to now age 23 over time. And we can look back at the early environments. More to the point here, we now have intervention effects to show that if we can change that family environment and the child's self-regulation skills before age 3, they're going to look a lot better in all kinds of, preventing all kinds of problem behavior by age 16. And we haven't even published that data, but we have it up to 14 now, and we've done the data analysis. So there's a good argument to be made here. From public health and economic perspective, it seems reasonable to think that preventive strategies could attenuate these trajectories of high adversity. We aren't going to save all these children, but we can get a high proportion of them if we can act early. And I realize I'm probably preaching to the choir here. So, if so, how and where? The use of public health care systems. So here's another reason to invest in this area. Pediatricians, daycare providers, women, infant, children, nutritional supplement programs, WIC providers, and preschool teachers and administrators, they all suggest the need. But they either lack the expertise and or the time. So I work with a lot of very well-meaning pediatricians, and they don't have the time, and sometimes they think they have expertise and they don't, and sometimes they do, but it's kind of variable in that way. But they clearly suggest they don't have the time over that, and a lot of our other providers. So how do we add that expertise in a way, in pediatric settings, it isn't a burden, because everything's rush, and you don't have time, you don't have space, you don't have anything to do, or how can we integrate in some place like early Head Start, which I know that Lisa and colleagues are doing here over time. Big question. Then once you get there, how do you identify children and families? Do we leave it to, let's say, informal processes? We've been doing a project the last year at a Head Start center, and a colleague that I've known for 30 years, I find out that how do you refer people for extra treatment there? Well, we have this feel, and we kind of talk to the families, and it's like, whoa, so we tried to place an intern there, and they couldn't get cases because they didn't feel comfortable with it. It's like, this is really seems arbitrary to me. We can do better than this, is what we hope. And then imagine you could identify at-risk families or families that are struggling by their own admission, right? How do we engage them in something they're not expecting? Like, I'm not expecting to get mental health services at my Head Start. I'm there for my child's education. Certainly not expecting that when I get my check at WIC sites. How do I engage families there? So what are some advantages of using public health systems to provide preventive interventions? Well, first, parents already have a regular to semi-regular contact with these systems. I used to be a street photographer, and one of the places I loved to go was the barbershop, because people were stuck there. And if I got permission of people to sit in the robes, I could gently ask to take their pictures. Well, people are already coming into a pediatrician's office, right? They're already coming to WIC, and they're sitting and waiting and doing nothing, right? And presumably they care something about their child, or else they wouldn't be there. So there is this captive audience, and then there is this sense of trust. In some cases, at least, parents might have a positive to, in some cases, very positive relationship with these systems. So pediatrics is the one that comes to mind and kind of in my heart, because we see a lot of parents, they may not trust other parts of the healthcare system, but they like pediatricians a lot. Early Head Start, the home visitors, they usually have this really nice relationship with, and I know there's classroom versus home-based versions of that. And Head Start, a little variable, but generally positive. Those seem like very logical places to go. In cases where trust is already high, you're in really good shape. You can capitalize on this trust to increase the probability of engagement in your intervention. But what about those places where trust is, let's say, mixed or not even high? It actually might be a way of convincing that health system that your intervention could improve the trust. So we're actually working with WIC at the state level in Pennsylvania now, and the way they're selling our parenting program is to say, well, we had this huge drop-off in WIC enrollment after the first year of life. If we add this parenting program, maybe that could increase families staying in the program. We actually have the money to give parents, but they drop out after that first year. Apparently, after you stop breastfeeding, the incentives go way down for staying in WIC, as I understand it. So this brings up the need to screen. So I'm going to throw this out here. This is meant for most of the researchers in the audience, not all you guys still in school here. But if you have an intervention, and unless you can suggest your intervention has universally positive effects for every family, it kind of behooves researchers to do the work that identify families for whom the intervention is most and least effective, right? It makes sense. We're wasting a lot of people's time, and I will, in the next presentation, throw family checkup kind of under the bus for this in a few minutes. So if moderators of treatment response have been identified, it means if there's certain characteristics of families that say this is a great intervention and this will do you no good. We should know that, right, as consumers and researchers. It leads to the need to screen families within public health systems to reliably identify children who are not only at risk, but who are likely to benefit from the intervention. Again, I'll show you an example of this and how this varied across 3 sites based on family constellations prior to the match. It's very nice. Usually I get interrupted with different buzzers and alarms. This is very soothing. It's great. Engaging families learning the hard way. So this is my sad story that goes back to our basic research. This was a sample of 310 low-income boys we recruited in the Pittsburgh area back in the early 90s. And we were not offering clinical services, but we were referring families when they scored like a 9 on the Beck Depression Inventory, which considered mild depressive symptoms, or kids had high scores on the Child Behavior Checklist. And for $2 an hour, they, in the same building, they could see a clinical psych graduate student for services over time. Of 310 families, we referred 148. The mean score was 8.8, so we had a lot of families at 9 or above. We referred 148 families to a clinic. We also referred to Jewish Family Services and Catholic Charities, but there was $50 to $60 an hour, even back in the early 90s for those services. How many think more than 50 people came to our clinic based on that wonderful $2 an hour referral? Raise your hand if you've got 50. Not no takers. How about more than 25? Yes, good. There's some optimistic. How about more than 10? Anybody? Yes. Well, 3 people came. 3 people came, and I know this because I was directing the clinic. A faculty member was away, and I was also directing our child family team. So I got to learn about this. Is over a 2-year period. 3 families came. Broke my heart. It's like, why are we bothering to do this research? So guess how many showed up? Why didn't they show up? Transportation. A lot of our families had to take 2 buses to get there. We did offer night hours, but we couldn't guarantee childcare over that time. And then there's this whole thing of motivation. We identified the families. Big deal. That doesn't mean I want to come in. I might have attitudes or distrust of mental health services / government. I mean, there are all kinds of reasons. Clearly, we were not offering this at families' homes either. So we made it wasn't very user-friendly, and it wasn't very reliable. But still, 3 out of 148, You do the math. That's not a very high percentage, and I'll come back to that in my next talk. So, how can we capitalize on strengths? By definition, families are likely not expecting to receive parenting services in this setting, right? That's the whole idea. We're going to bring this to the setting. How are we going to engage families and use the current system staff to facilitate this over time? This means, and again, I'm probably preaching to the choir for those of you who've done this, you need a champion. You need many champions inside that organization. How do you get champions? You're not just going to have to engage them. You're going to have to partner with them, right? You're going to have to make it and make it their own intervention over time. It can't be theirs from the start, but it can be theirs if it's going to work over time. So you're going to have to invest time in organization to make the connections deep with multiple staff, not just the person who leads it and is never there except one day a week. That's not going to do it. What about receptionists? What about how is this going to work inside this setting wherever you are? Is it going to be one more thing I have to do? Oh, great. And a lot of times we've been doing these implementations and the staff are already using 5 different models. These are the clinicians handling it. You're adding a 6th. Great, just what I wanted to do over time, right? So we tend to try to go to settings where there's never been an intervention before to avoid that, but it is there over time. So who will be the point of contact person for the intervention? In the pediatrics, we're in a university setting, so the residents that come through, and they can talk up or not talk about the intervention too. Nurses, receptionists, everybody, the docs, everyone, we got to get everybody on board and make it their intervention over time. So then there's this broader idea. Now I'm going to step back. How do we make a difference at the population level? So if you're thinking about working with families most in need and getting to those, then the rest of the slide may not be as applicable as what I'm thinking of here. But if you are more concerned with reaching a larger number of families within public health systems, I think some of the information might be valid. There are large differences in the populations of, I see this is a different version of the slide I had. That's right. Large differences in populations of at-risk children served among systems. So this, what you can't see at the bottom here is a graph, which, again, this is the wrong version. This is a graph of Head Start families from 0 to 5. That means it includes those in early Head Start as well as Head Start. And although I have a different version of this graph, what you see is most of this pie chart is based on 4- and 3-year-olds. So Head Start, it's been estimated, serves about 41% of eligible families who meet eligibility criterion. Early Head Start serves about 3%, right? So if you're thinking of making, and unless society tries to change that funding, there's going to be a ceiling on what you're going to do in impact. Even though you think you want to start with early childhood, if you want to make an impact at a larger level, it's going to be that. So capitalizing on strengths, what do you have in your local community? I know we're going to hear about some of those great ventures today. But capitalizing, so in Pittsburgh we have what's called family support centers, and these are throughout Pennsylvania, where thanks to the head of Department of Human Services, Mark Chernow, like 25 years ago, identified low-income areas where it wasn't safe to cross the street in the morning, much less raise your kids. So these centers are wonderful places for families. They're underserved, of course, families don't use them, but wonderful places to locate interventionists in the community where you can walk down the street or have someone come from that center to you. We also have this program for maltreatment where alleged first-time offenders get treated. Again, this might be a point of opportunity we want to capitalize on with our parenting intervention. So as I mentioned, if I was going to start and thinking about population impact, I might want to start in pediatrics. In 2011, 91% of American children under the age of 2 had at least 2 child care visits, child visits. 91% of families. If you're looking at the population level, pediatrics makes a lot of sense from that angle. And then there's making the intervention function in the new setting. how adaptive or mobile is your intervention over time? We're pretty mobile in the family checkup. We're working, Pamela Morris is going to speak in the next hour about a video interaction project, which is something we're joining forces. We're like the Avengers. We have 2 interventions instead of 1. And part of one of the major strengths of a video interaction project is that it's located in pediatric care by design. The developer, Alan Mendelson, and our collaborator, was thinking of this very strongly. Well, now we're working with babies where there's been opiate addiction in the mom. And we're finding they don't necessarily stay in the same pediatric center, they don't necessarily stay in the same rehab center, and we're going mobile, right? Meaning we are now taking video interaction project and doing home visits with it, or going to the rehab center with it. So how adaptive is it going to be to the families you're working with? How much is the public health setting a passive recipient versus active collaborator in implementing and are designing the intervention? And this, I must say, we've learned the hard way, trying to come in and say, we've done focus groups and things like that, but really kind of changing the crux and the core of the intervention, which can be really gut-wrenching if you're invested in creating an intervention a certain way. So at WIC, being more aware of nutritional development and helping WIC staff get reminders with appointments or giving out handouts to make sure they're aware of things like that. Ironically, we got effects on BMI in our family checkup, which has nothing to do with nutritional development over time. How can we fit? And so instead of engaging with the agency, partnering with the agency, which is a very different feel than coming and looking down, but really working with. So, what I've tried to do very briefly here, am I right time-wise? We're good?
Yep.
This is my last slide. I think we clearly have the empirical and theoretical impetus for implementing early childhood parenting programs in public health settings. I think we clearly have some programs, many of which you're going to hear about this morning, this afternoon, that have more than begun this journey. But clearly there are also lots of challenges to navigate, but an abundance of opportunities to make a real and lasting impact at the population level for the future success of coming generations of our nation's children. Thank you very much for this part of it.